I'm Matt Skinner. I'm the Director of Therapeutic Endoscopy down at Scripps Clinic Hospital in San Diego. Today we're playing with the Ovesco full thickness resection kit. We've already loaded the scope with this device. This is used to achieve a full thickness specimen. Typically on colonic lesions, there's a little bit of usage of this in the upper GI tract. But this is essentially an oversized Ovesco clip with a really deep cap, and that allows you to capture a lot of tissue. We're going to use sort of rat tooth forceps to capture the tissue. Typically what we would do is we would find the lesion endoscopically without this cap on. So we go in with one scope. We're going to mark around the lesion because the distance here is a little far. If you don't mark that lesion, it can be slightly difficult to find. So we mark that lesion up front to make it super obvious during the procedure. It is a big device, so you got to be careful when you're sort of working it through the GI tract. Typically, we're working in a plastic model here, but typically it's a lot of reduction, it's a lot of underwater intubation. You got to be really slow with it, especially in these sort of right-sided lesions. If we have sort of these right-sided lesions and patients have a lot of diverticula, that's probably the most challenging part, is to get the scope to the right side there. So we're hung up somewhere here with our plastic. You know what? I bet the plastic sheath is creating a lot of friction. So now we're getting to the right side of the colon here. I think the plastic on plastic is just creating some friction in the system here. There we go. So now we're out in our pig's stomach here. We kind of straighten this out here. So what I don't want to do is I don't want to kind of grab that plastic. See this O-ring here on our model? I don't want to be grabbing that, so I want to be able to get through this area. There we go. All right. So what we're going to do is we're going to find our lesion, try to find where that is. You can hand me the rat tooth here. So we don't exactly have a lesion. So I'm going to make sure that the string is taut, but not too taut. I don't want to deploy that clip yet. But you can see here the metal clip is kind of hanging out here and then here on the full thickness device. So I'm advancing the forceps down through. And typically I'm going to have two people assisting with this procedure. So I have somebody who's controlling our forceps, and then I have somebody else who's going to be controlling our snare. This snare is actually built into the cap here. So conceptually, you're going to pull the lesion into the cap, you deploy the clip, and then you're going to snare everything above that clip in one smooth motion. So what we're going to do is we're going to open our forceps. I'm going to have you grab that here. So this is our lesion. And I want to keep this on FOS. I'm going to pull back a little bit. I'm trying to get some of the tension out of the system. Kind of gets, really, they say no suction. I think a little bit of gentle suction to kind of massage this thing in. I don't know if I would put on the suction and slam it and hold it, but just to kind of get things finagled and started here, we can get some suction going. You always want to create a little bit of separation. So I'm continuing to kind of finagle the cap back and forth, and that allows me to get more and more of this lesion in. So once I have my lesion fully withdrawn in, I'm gonna deploy this FTRD clip so we can take this off here and make that hot.
Any concern about grabbing your retraction device? How do you assure that you won't?
You certainly want to make sure that you should have good visualization. So we have our retraction device here. You want to make sure that you can see that retraction device. Another reason not to throw on full suction, you got to know where that retraction device is in relationship to the clip. Same as when you apply any Ovesco clip. So I'm going to twist this. You're going to watch this white ring move forward. And as you do that, do we have a pedal here? Do I have a cautery pedal?
Not something that doesn't happen in the lab itself sometimes.
All right. And this should be on an auto cut setting here. We're on the Irby auto cut setting here. All right, so I'm going to start to deploy this clip. As you see that white ring go forward, so you're going to see tension there. And you'll see this clip deploy. All right, close that snare. Okay. And there, we're going to hold on to it still. We're unlocked. And now we're going to withdraw with our entire specimen here. And then that specimen is going to play out. You can drop it. And we should have a nice full thickness specimen here available for us. I'm typically going to pin these specimens out so that I can orient them for the pathologist, same way that I would do with an ESD. And then every single time I'm going to take the cap off here. I'm going to remove all of this and I'm going to drive all the way back out there to go just make sure that there's no perforation, there's no bleeding, that it looks like we got the entire lesion, that there's no kind of residual tissue. All right.
Thank you so much.
Yeah.
Are there any other Ovesco over-the-scope clips that you would like to mention that you use in your practice?
So for the upper lesions, you can do the same thing. They actually have a new device out now to do duodenal lesions, to do gastric lesions. Before they had that, we were using sort of the diagnostic version of this, which is very similar in size. For the upper lesions, you typically, it is a big device to get through the UES. So we typically were dilating everybody with a 20 millimeter bougie savory dilator prior to that.
And the other products, the other over-the-scope clips, have you used for stent fix?
I haven't, yeah.
And
yeah, so typically if I'm closing stuff, I'll use an Ovesco. And you know, the nice thing about these is if you're dealing with a rectal lesion, you don't necessarily need the sheath. You can use it on a therapeutic upper endoscope and get there pretty quickly and easily. So, yeah. And I'd say that the key is just be patient getting to the lesion, and then the other key is just be patient coaxing that lesion into the cap, because if you try to rush it, you're going to rip that tissue. You just got to be very patient with it, and it'll eventually move for you.